It is a delight for me to be here with you this morning. And I hope that in the next 20 minutes, I'll be able to share with you the story of what it is that Kenya has done. But beyond that, I hope that it will be an opportunity for you to learn about what perhaps you in Pakistan could also do differently. So, as you've been told, my name is Elizabeth Bukusi, and I've had the privilege of being part of the CBEC family for quite a number of years now. But today, we're actually talking about ethical responses to the evolving HIV pandemic. And I was asked to talk about the Kenyan story, thinking about whether we have come from crisis to progress and lessons that we have learned about the HIV pandemic in the last 40 years that HIV has been around. This is me, and there are many institutions I'm privileged to be part of. I'd like to particularly mention the University of Washington, Seattle, where I am a research professor in the departments of obstetrics and gynecology and global health. So let me talk a little bit about just what I've learned, and this is statistics from UNAIDS about Pakistan. In Pakistan, your epidemic is what we call a concentrated epidemic. It's generally a low prevalence, but it's just in a few specific areas where there is quite a number of individuals who are infected with HIV. So even though it's actually below 0.2%, you currently have about almost 300,000 people who are living with HIV in Pakistan. Who are these individuals? They are what we term as key populations: people who inject drugs, transgender populations, sex workers, men who have sex with men, and within your prison populations, those are the places in which HIV is largely diagnosed in Pakistan. There are cities, and I'm sure you will recognize them even better than me, where the epidemic in Pakistan has been concentrated. It's really largely in urbanized settings. This is, as you well know, Karachi, the one city that I have spent the most time in, the times that I have come to Pakistan. And I'm sure you can recognize these other two cities, especially those of you who are from these cities. So, to be specific, in Karachi, among people who inject drugs, it has been recognized that HIV can be even up to 49% in some surveillance rounds that have been done. In Lahore, there is a large concentration of men who have sex with men and transgender people and sex workers, and it has been a city that has had a number of HIV programs. Hyderabad in Sindh is an important hotspot where people who inject drugs and transgender populations are of concern. And Lakhana in Sindh is also known to be a city, and this is one of the ones that I think has been mentioned about a pediatric outbreak that was reported. And this was really a large because of transgender populations and female sex workers. Which turns me to the attention of our story in Kenya. What has the story been in Kenya? Kenya, I'd like to tell you what is happening now, and then I'll take you back to where we were 40 years ago when the pandemic first started. We have one of the largest HIV programs in Africa, but it remains a public health issue, especially in the light of dwindling international support. And particularly from last year, we have had a very big challenge. Currently, we think that between 50 to 49 years, we have an HIV prevalence of about 3.3%. Women are definitely more affected than men, which tells you why this has been a concern for me as a gynecologist, because my focus has been the health of women. Kenya has about 1.38 million individuals living with HIV. Now, just to put it in context, I believe in Pakistan, your population is about 200 million. In Kenya, we are talking about 50 million. So just see that in context in terms of our numbers versus the population that we are working with. Where are the places that we have concern about HIV? Ours is a generalized epidemic, unlike yours, which is a concentrated epidemic. And we have 47 different counties in Kenya. The counties where we are most concerned are Homa Bay, Kisumu, Migori, Siaya, Busia, Mombasa, and Nairobi because it is the capital city. My work is concentrated around Kisumu, the place that has one of the highest burdens of HIV. Just to bring the point home, the burden is actually around the cities that are around the lake region in Kenya. Nairobi is one of the places with the highest burden. Kisumu, the city where most of my work is built, which is around Lake Victoria, a lake that is shared between Kenya, Uganda, and Tanzania. And at the coast in Mombasa, that is where we have a very high concentration of HIV. So let me take you back to 40 years ago, almost 30 years ago. I was a fourth year medical student when HIV was first diagnosed in Kenya. I didn't realize how much it was going to change the trajectory of my life, but it made a big difference. In those years, there was so much fear. When someone was diagnosed with HIV, even the consultants didn't want to go into the room where the individual was being seen. If someone died of HIV, they were wrapped up in big plastic sheets of paper, similar to what we sort of saw during the COVID pandemic. People wore a lot of protective gear because there was so much fear and people didn't know what to expect. People were stigmatized. A little while later, once we realized that yes, though it was infectious, it was not that highly infectious, there was a little bit of change. We had no treatment to offer people. We talked about death with dignity. What did that mean? We talked about home-based care, where we provided care because we had nothing else to offer them, and essentially watched people shrink into skeletons of themselves and pass away. For me, HIV came home when I worked as a young medical officer on the border of Kenya and Uganda in a little town called Bukusi that is still one of the hotspots for HIV. As a young medical officer, when people came in to bring children who had malaria, because this was a high malaria burden area, automatically we asked parents to donate blood for the severely anemic children. Those days we didn't have rapid tests. You donated blood and then we tested it after. I saw us discarding from 1 in every 10 in the 2 years I was there to discarding 5 or 6 out of every 10 because they were infected with HIV. That is what shaped my career and my work in HIV. It also shaped my career as an obstetrician because I saw a lot of morbidity and mortality linked to women's health. And that made me want to be part of making a difference. Back to the Kenyan story. If you even look at 2014, now we're at about a prevalence of 3.3%, but by then we were still at a very high prevalence of 5.6%. This is the area that I work in. It was then called the Nyanza province before we became into counties, where we have Kisumu, Siaya, Migori, and Homa Bay counties. This purple tells you the high prevalence of HIV that was being seen even then. Showing it even closer, Homa Bay and Suba were even more affected, with these rates as high as 24 to 30 at that point in time. The question was, how do we make a difference? Thankfully, antiretroviral treatment started becoming available, and the PEPFAR program set by the United States of America became a reality for us that we could implement providing care. The question was, how do we do it? Infected populations, and especially those who are rapidly getting infected, were the younger population. Those who are actively engaged in providing support for their families and being part of the workforce. We started a program that was called the Family AIDS and Care and Education Program. It was a PEPFAR-funded program, and for 15 years, we expanded care to provide care in these very areas that I've shown you before, expanding care to provide care in places where there weren't available trained physicians, and making sure we could capacity build in order to be able to ensure that people could get the care. Taking it to the very smallest, very closest facilities where people could come in and be able to get treated. Beyond that, we realized that it's not just about treating an individual, it's about treating a whole community. Because of stigma, because of challenges with structural determinants like poverty, people often struggled just to be able to have enough transportation to come into a healthcare facility. Sometimes they could come to the health facility, get their medication, they didn't have food. They were unable to take their medication. They didn't have clean water. So we realized there were so many other things that we needed to be able to provide. providing a family-centered counseling that enabled us to find every individual who was infected within a family, provide family support so they could come together, counseling so that they could give each other the support they needed, enabling treatment, and then looking at all the other structural determinants around them to ensure that they could be catered for was what we needed to do. Children needed hope. It was not just a question of they were infected. How could they be part of a supportive community of other individuals who were like them? So children's clubs became part of what we did. For some women, they wanted to ensure that they did not have any more children. And at that point in time, perhaps access to contraception became important. So it was a holistic approach, ensuring that individuals could get the services they need for what they needed to ensure that their whole life cycle was taken care of. Then came the question, what about those who are not infected? Those infected in any population will always be a small number. The number who are not infected are even more. How do we make sure what has been described as perhaps a leaking tap does not continue to leak? Because you can never keep a flow clean if the tap continues to drip. It became the question of, can a pill a day prevent HIV? Prophylaxis had been done for many other conditions, including things like malaria, when people travel to malaria zones. And the question was, could this work for HIV? We were part of one of the first studies that showed that indeed a pill a day could keep HIV away. Working with discordant or serodiscordant couples was the way that we showed that HIV could actually be stopped from being transmitted from an infected partner to a non-infected partner if the infected partner could take a pill a day. And it was not just about showing that this could work. It was about, could we take it even further? Ensuring that we translated what was shown in clinical trials into actual practice, into demonstration studies in a real world setting, unlike clinical trials where you're really searching for the participants, following them up, making sure that they take their medication. Would it work in a real world setting? It did. And so the Kenyan Ministry of Health, and really it was WHO who also convening the task force as they usually do, was able to ensure that this could be made available. So Kenya was able to implement pre-exposure prophylaxis for those at risk to ensure that those who were HIV negative could choose to stay HIV negative and not get infected. The question went beyond, was it only healthcare facilities? Because many people who are HIV negative do not want to come to a healthcare facility when they're well. And so we have been exploring other ways of being able to provide pre-exposure prophylaxis. For example, pharmacies, which is one of the things we're working on now. And now, as many of you may be well aware, we've gone beyond a pill a day. Many people cannot take pills every day. Even those who have chronic diseases get to a point of pill fatigue and stop. So now we're exploring other options. We now know lenacapavir can be taken once every 6 months, and we are now expanding access to that. We know cabotegravir can be taken once every few months, 2 to 3 months. And so that is also a way. But not everybody wants to take a pill or an injection. Now we're looking at pills that can be taken once every month for those who may not want an injection. And we hope that these will be providing what we call supermarket options. People like supermarkets because you can find something that fits your lifestyle, something that works for you. The lakeside is an area that we hope that we have made a difference, and we have seen many families being able to get on with their regular lives because treatment has been made accessible and because prophylaxis is also a reality for them. But the real question is, what are the ethical concerns? Are there things we need to pay attention to when expanding HIV care? Are there lessons that perhaps Pakistan and other countries can learn and that Kenya is still learning because we are not there yet? There's still so much that we need to do. Allow me to use animals from my country, from the African savannah where I live and work, to be able to illustrate some of these points. Elephants live in community. One of the important things about elephants is that they have a long memory, but they really stay close to their families. They do not leave family groups. It is the male who often will get kicked out, but the matriarchs and the rest of the family stay very close together. The ethical issues we need to address here are ensuring that there is local involvement. We must be able to say exactly what the theme of today's seminar is: nothing about us without us. Involving local communities to design and implement both treatment and prevention is really important. We must respond to the real needs. What Kenya has done may not necessarily work in Pakistan. Pakistan is a different country with different communities, with different religious affiliations. And so you need to be able to pay attention to those things when designing any programs. There must be feedback mechanisms that allow communication, that allow the concerns and voices of the community to be able to enable adaptation that allows programs to actually work, whether it is treatment or whether it is prevention. Every buffalo may look the same to you. These are one of the animals that cause a lot of damage to individuals if you attack them. Buffaloes are known to fight even lions. And when they gather together as a community, it's very hard for lions to actually target them. They will look for the one that has been left behind, the frail one, or the one that isolates itself from the rest of the community. The interesting thing is, buffaloes are not all the same. Each one is quite unique. Ensuring, however, that when you are providing this treatment and prevention, that there is equity, that regardless of anybody's socio-economic status, they can all have access to treatment, whether it is treatment or whether it is prevention. Ensuring that it is affordable, that the costs that can be very high of medication are brought to a level where individuals can actually get access. Is it through insurance programs? Is it through subsidized costs? Whatever it is, it needs to be affordable. But in order to deliver this, the infrastructure must work. For many lower middle income countries, we lack the essential healthcare structures that make it possible. And even when we make it possible, our healthcare services can sometimes be very stigmatizing. People do not feel welcome. People are kept waiting for long hours for a very long time, or made to walk from one queue to another, depending on the services that they need. Making sure that there is access is very important. Treat each buffalo differently. Each person should be able to get the services that they need. The cheetah is known for its speed. It goes from 0 to 65 kilometers per hour in about a minute. This doesn't work when it comes to issues of consenting, whether it is in healthcare or whether it is in research. We cannot do things at speed that leaves our participants behind or leaves our patients not understanding what it is that they need to do. The cheetah has to employ speed because it cannot sustain. Its heart rate is such that it would not be able to sustain that speed for a long period of time. It must be strategic and catch its prey within that short spurt that it takes. We need to slow down, unlike the cheetah, and ensure that our patients fully understand, our participants in research studies truly know what it is that they're signing up to. Because none of the medication, none of the research studies that we do is ever without risk. Nothing doesn't have some kind of a side effect. And people must understand we have to be culturally sensitive. The consenting process is not always the same. How people are consented in the US and in Kenya and in Pakistan may be very different. Pakistan, you have a really excellent, strong community support. It is an advantage in many ways. Sometimes it can be a disadvantage as well and can make it challenging. But we must be able to respect individuals' autonomy and ability to be able to make decisions while taking their cultural considerations into consideration as well. Because can they disclose? Who will they disclose to? Who is their support system? Who needs to know? Who must know? Who doesn't need to know? These are things that you must be able to take care of. Leopards tend to be very individual. But one of the interesting things about them is that They are very committed. A leopard is so strong that it can carry its prey way up into the trees so that it's able to keep its prey from marauding lions, which they cannot fight because lions are in prides, and because they need to be able to protect their kill. We must think about the sustainability of our programs. Whatever it is we decide to put into place, we must think about the commitment of those who support us and the long-term commitments of governments. Primarily, every citizen is a responsibility of the government that governs it. So we must have a view that allows us to ensure we are doing everything possible to protect our citizens. Sooner or later, there are exit strategies. What we do not need is exit strategies that are sudden, that pull the rug from under our feet, that leave people stranded, that stop healthcare workers from being able to provide care, that take commodities out of the shelves people cannot test, cannot get treatment. We must be able to avoid dependency on a long-term basis. So we must think about long-term commitment. The lion is called the king of the jungle. I've always wondered why, because elephants are actually a lot stronger than lions are. But there's a lot of things about lions that are very admirable. They protect their pride. They work in community. The male lion is very protective of its females and of its cubs, except for the cubs that it thinks might want to usurp it, then it's very quick to kill them. How do we protect personal health information? The safeguarding and ensuring confidentiality of individuals' health information is important, especially where we know that there could be populations, like key populations, where there is stigma. Men who have sex with men, people who inject drugs, sex workers, transgender population. There is a lot of stigma. Can we ensure that in the process of providing care or prevention of HIV, or even doing research, that we ensure that we are safeguarding personal information? Can we share data in an ethical way? Because sometimes data is needed for public information in order to be able to make appropriate decisions around programming, around ensuring that care and prevention can continue. But we must ensure that we are carefully managing this. And we must really take the lion's stand in safeguarding information that is provided for us. The rhinos have very poor sight. They rely a lot on their really keen sense of smell. When rhinos commit, they charge. When rhinos are attacked, they fight back. This has been the space of HIV for many years because of social stigma. People have faced a lot of stigma, which has made it difficult for them to seek treatment or even participate in research. It's also made it difficult for them to disclose, sometimes to family members, even to their own detriment. Women and other marginalized groups have also experienced additional stigma. I always think about the fact that there are very few people who probably make a choice about, shall I go into sex work? People who perhaps are transgender often do not have the choice of whether that's a lifestyle that they're choosing or not. Circumstances and structural determinants often put people in situations where they do not have much choice. For those of us who may have been privileged and have choice, what is our attitude towards them? Do we place them in a position where they're always having to charge, always having to defend themselves because of circumstances that they have, like the poor eyesight of the rhino? Are we allowing them to be able to come to the table and tell us how can we truly ensure that they're getting the services they need, given that they may have started from a space of great disadvantage? Hippos cause a lot of damage to people who live around the lake, not only because they destroy crops, but because amazingly, despite its size, the hippo is very agile. And when surprised, it actually also runs very fast. So many people who live around the lake get a lot of injuries because of hippos. People worry more about crocodiles, but crocodiles stay a lot in the water. Hippos actually get out of the water to graze. but they're also very vulnerable in very many different ways. With the advent of the changing climate and water that has been getting less, hippo populations have also been getting affected. I want us to think about research because in the process of doing research, we must ensure that vulnerable populations are included and not excluded. But in the process of inclusion, that we must ensure that their rights are guarded. For those of us who live in low and middle income countries, our countries are often easily available for research on a variety of different conditions that also impact the higher income countries. While this is fine and can be very ethical, we must make sure that there's adequate benefit sharing. That research is never done in populations that cannot benefit from whatever research product they are part of. And we must also ensure that there are adequate research regulatory systems. From a while ago, Kenya has improved its research regulatory systems. We now are able to ensure that committees are accredited, that they meet international standards for an ethics committee, and that research cannot be done in any part of Kenya without an accredited committee having reviewed and approved the protocol. Kenya now has actual jail terms or fines for anybody who is found to violate our research regulation. Is Pakistan taking care of its citizens? Do you have an accredited system? Do you have enough ethics research committees in your research institutions and in your universities? Are you ensuring that the standards and the training for those who sit on those committees is adequate? Are they safeguarding? Because the role is not to stop research, it is just to ensure research is done because it is needed, but also ensure that the welfare of the participants is taken care of, that nobody is put at undue risk, and that everybody has the opportunity to be part of research if they can, to contribute, but also in the long run, the communities they're part of can benefit from research that is done. So, in essence, what have I been saying? The giraffe thinks ahead. Its long neck allows it to be able to see far. It can see predators from afar. And even when the land is very dry, giraffes stay healthy because they eat what nobody else can eat, the top of the acacia trees that no other animal will easily reach. Our approach to changing the landscape for HIV prevention and treatment must be collaborative. It must be one that respects the local context. It must prioritize the well-being of individuals and community at every level, and it must be sustainable. That is the only way that it can be truly ethical. Our goal for me and for many of us is to ensure we have generations who are born healthy, who live well, individuals who can reach their full potential without the threat of infections like HIV or anything else that might come our way in the future. We live in an uncertain world where things shift. But for the things where we can make a difference, we want to be able to make a difference and do it ethically. Thank you very much for listening to me. And I'd be happy to take a few questions if anyone has them.
Dr. Bukusi, thank you so much for just such a beautifully articulated presentation. And you've really set the scene for the remainder of the day. And I think you've highlighted again so well that any kind of progress for HIV is going to require us to build an ecosystem, and that, you know, this ecosystem, the basis of it is going to have to be trust, participation, and sustained commitment. And your last slides about collaboration, local context, individuals and communities at the center of this, and to obviously ensure that it's sustainable is just fantastic. So thank you very much. We are running a little behind time, so we can open for 2 questions.
So it's, I think, Dr. Anleeb Hanif, she wants to ask, how do we move from knowing what is ethically right to actually making institutions accountable for delivering it? And importantly, how can people living with HIV and vulnerable communities can have a meaningful role in that accountability rather than remaining only the recipient of these programs?
That's a really good question and really difficult to answer. I would almost say that each one of us has a role to play. We can't wait for somebody else to make those choices. Each one of you who is a physician, who's a nurse, who's a healthcare giver, who's a community member, has a role to play. We are the same people who discriminate. We are the same people who create stigma. We are the same people who can provide services. We are the same people who can advocate to hear the voices of others. There are laws that can be very discriminative and can be damaging and even put people at risk. We have to keep advocating and making the steps that can start to create opportunities that allow these voices to be heard. Creating safe spaces that allow people who would otherwise never speak and never say what they need so that we can hear it and we can make a difference. So I would say the question I would leave you with is ask yourself, what can I do as one individual? I think if each person does a little bit, whatever they're able to do, then we end up turning the tide. Thank you.